So good morning to one and all. I have two abstracts to present. The first one was in the JCO, published, that is the partial breast radiation versus whole breast radiation for the early breast cancer in a randomized phase 3 trial. This was a DBCG trial presented by Bagatti Offerson. So you all know it is well documented that adjuvant radiation in breast cancer lowers the risk of local regional distant failures and improves the overall survival. Apart from WBI, PBI has also gained a lot of interest given the fact that most local recurrences occur in the near or primary tumor bed, making it possible to use PBI without increasing the risk of recurrence. Initially, DBCG hypo trial tested WBI 50 grain 25 versus 14 15, but this trial was randomized equally where they tested 40 grain 15 versus 40 grain 15. The hypothesis was that PBI would neither cause more breast induration than WBI at 3 years nor compromise the local regional recurrence rate. So the design was 1:1 randomization where the total number of patients were 880. The inclusion criteria was just like Astro APBI consensus, that is age more than 50, ERPR strongly positive, HER2 negative, T size of less than 2.1 centimeter, non-lobular histology, grade 1 and 2, and patients with bilateral breast, previous breast cancer, and breast implants were excluded. The dose plan was 40 grain 15 fractions in both the arms. The primary endpoint was breast induration, that is the clinical marker for fibrosis. The secondary endpoints were also reported according to the lensoma tables that were telangiectasia, dyspigmentation, evaluation of the scar, edema. Recurrences were local, regional, and distant. So moving on to the results, the median age was 66 years, the follow-up period was 5 years, and the 3-year rate of grade 2, grade 3 induration was 9.7 versus 5.1 with a p-value of 0.14, which proves the hypothesis that it was non-inferior. Large breast size was significantly associated with induration with a 3-year incidence of 13 versus 6, and for large breasted patients versus 6 and 5 for the small breasted patients. PBI showed no increased risk of dyspigmentation, telangiectasia, edema or pain, and patient satisfaction was high. So there's no difference in local regional recurrence rate or OS. So this graphs shows about the non-inferior study where the grade 2, grade 3 induration between the PBI and WBI, and the below table shows the complication that was induration, dyspigmentation, telangiectasia was almost comparable. So the authors conclude the DBCG PBI trial provides long-term robust evidence in favor of moderately hypofractionated external beam PBI. The DBCG recommends this treatment for select patients based on the APBI Astro consensus. The breast mobility was low for all patients and cosmetic outcome was favorable and mostly even slightly better after PBI. So the hypofractionated PBI, that is 40 grain 15 for early breast cancer, does not increase the risk of breast morbidity irrespective of the breast size, use of letrozole or smoking. The important factor is not the breast volume per se, but rather the irradiated volume. Thus, for large-breasted patients treated with PBI, the risk of induration was at the same level as for small-breasted patients treated with whole breast radiotherapy. Trials which were done previously like RAPID and NSABP or RTOG 0413 and of late APBI Florence have all reported moderate to severe late morbidity, which is basically attributed to twice daily fractionation. But still, considering previous PBI results, this moderate hypofractionation trial has proven to have less morbidity and patient satisfaction was high in this trial. So the take-home message, DBCG hypofractionated PBI can be offered to select group of low-risk patients. Grade 3-year, grade 2, grade 3 breast induration was similar, which was non-inferior. The breast mobility was low for all patients and cosmetic outcome was favorable. Larger breast volumes are significantly associated with induration. Moving on to the next abstract, which is the effect of elective internal mammary nodal radiation on disease-free survival in women with node-positive breast cancer, published in JAMA Oncology by Yong B. Kim. So the internal mammary, that is IMNI, has always been a subject of controversy since the time radiotherapy has shown to improve survival in patients with early breast cancer. MA20, the previous trial, EORTC trial, have shown benefit and reduction in breast cancer mortality and recurrence, but in both these trials, the RT was directed in IMN and SCN with or without undissected level 2 or level 3 nodes. Since all regional nodes were targeted here, which part of the regional nodal irradiation contributed to survival is very unclear. DBCG French trial also aimed to show benefit in IMNI, but both were in the era, very important, both were in the era when taxanes and HER2 drugs were not available as a standard chemotherapy regimen, due to which uncertainties, this trial, that is KROG trial, performed a multicenter phase 3 trial to investigate the effect of elective IMNI on DFS in node-positive breast cancer. So it was a multicenter phase 3 trial where 13 hospitals from South Korea were included. Pathologically axillary node positive, either BCS, mastectomy were included, and patients with distant mets and those with NACT were excluded. All patients, the number of patients were 747 were enrolled, 1:1 randomization was done. The primary endpoint was 7-year DFS. Secondary endpoints included the rates of OS, breast cancer specific survival, and toxic effects. The radiation dose was conventional fractionation, that is 45 to 50.4 gray, and tumor bed was allowed in the eligible patients. The mean age of the patients were 49, median follow-up was 100.4 months. The 7-year DFS did not significantly differ between the groups treated without IMNI and with IMNI, and the p-value was 0.22, but the subgroup analysis showed the 7-year DFS rates of 81.6 without IMNI versus 91.8 with IMNI, with a p-value of 0.008, and the 7-year breast cancer mortality rates also showed some improvement. So these were the graphs overall, not considering the subgroup analysis, which showed no difference in the DFS. And the author concluded, this trial raised the possibility of an improvement in DFS with regional nodal radiation in patients with node-positive breast cancer who received IMNI compared to those who did not undergo IMNI, but unfortunately could not reach the statistical difference due to lower than anticipated event rate with a corresponding loss of statistical power. This study finding suggests that including IMNI nodal radiation would be beneficial for patients with mediocentrally located tumors. Basically, the effectiveness of IMNI is always controversial, mainly for 3 reasons. First is the incidence, which is less than 1%, lung and heart doses, which is always difficult as a radiation oncologist to control, and an advancement in systemic therapy, which has reduced the benefit of IMNI. No significant benefit in DFS could be demonstrated for IMNI in patients with node-positive cancer. DFS benefit of 3.4 with IMNI was similar to the results of RNI studies, but in the present study, hypothesis, which was 10% difference, itself was overestimated. Yet authors did not proportionately adjust their interpretation of results. All the previous trials have included IMNI as a component of regional nodal radiation. So if you need to highlight the benefit of IMNI, onus falls on the investigators to design a powered non-inferiority study to evaluate this question rather than a superior study. Only subgroup analysis showed DFS improvement by 10% in medial and central tumors, but it was not planned upfront, so should be considered with caution. Lastly, no mention of toxicity. Cardiac dosimetry is never mentioned in this study and may be needed more follow-up to actually evaluate the cardiac toxicity. So the take-home message, IMNI node-positive breast cancer showed improvement in DFS, but was not statistically significant, mainly due to the lower than anticipated event rate with a corresponding loss of statistical power. 10% benefit in DFS was shown in medial and central quadrant tumors, but this should be taken with a word of caution in our practice, as this was subgroup analysis which was not planned upfront, and also keeping in mind the long-term toxicities. Thank you.